guidelines and management of POI. And whenever I exceed my time, I have exactly 27 slides. So please let me know, and then I can just jump to the last slide. What is important is that when we are looking at premature ovarian insufficiency, we need to have the right diagnosis. We need to assess the cause. How Dr. Sharma sir just said that it may not be genetic always. What is the basic assessment? Because we as gynecologists would be encountering these patients first, and maybe they will land up with endocrinologists or with fertility specialists later, and even they would need different consultations in conjunction with a lot of other departments to assess and to diagnose this problem. So how will we approach POI? We have to look at their fertility concerns, we have to look at their contraception, their cardiovascular issues, psychological issues, psychosexual functions, and neurological functions. So it doesn't just end just because the patient comes to our OPD and she is going through only fertility issue. So what term to use? Ovarian reserve encompasses both quality and quantity of primordial follicles, and premature ovarian insufficiency should be used in clinical practice. So we should not say that you are going through ovarian failure or premature menopause. So it's a clinical syndrome associated with loss of ovarian activity before the age of 40 years. And around 1% of the general population will show this issue in women. Now, is low ovarian reserve and POI the same? Though they lie in the same spectrum, however, POI will face challenges much more than just fertility alone. Now, they will be presenting with following symptoms: hot flushes, night sweats, vaginal dryness, dyspareunia, sleep disturbance, mood changes, and poor concentration. I am right now treating a girl who has an FSH of around 20-25, doesn't want right now any other gamete other than hers. She's a young girl. So after stimulating her for many days, I'm able to make a follicle, but she has so much of vaginal dryness that she's not able to have contact with her husband even during follicular genesis, and I have to give her one pill of an estrogen tablet, and that is how she recovers, when it comes to dryness of the vaginal wall. So diagnosis of POI, all the women with either amenorrhea or oligomenorrhea or estrogen deficiency below the age of 40 years. So when will I start suspecting it? When either there is oligomenorrhea or amenorrhea for at least 4 months. And secondly, if the FSH is more than 25 international unit on 2 occasions, more than 4 weeks apart, and then we can say that yes, this girl has premature ovarian insufficiency. Now, what are the must investigations? Now, if we have diagnosed this, even though she is coming to you at the age of 25 or 30 years, chromosomal analysis in all the cases of non-iatrogenic POI, you will see 21% with primary amenorrhea and 11% with secondary amenorrhea will have some chromosomal abnormality. Now, if in case you find a Y chromosome, in these, it could be XX and a little Y, then these girls will still need gonadectomy because there is a risk of malignancy. The third is fragile X pre-mutation, which is indicated. It's a level B, indication, and I'll show you that how it will help and how we can employ these tests, though we may not be able to change the prognosis or the ultimate outcome for the patient, but in some patients, we will be able to rescue their fertility. Now, screening for 21 hydroxy antibodies, which are adrenocortical antibodies, is recommended, and anti-thyroid antibodies to be considered in POI of unknown causes or if autoimmune disorder is suspected. Now, if anti-TPO antibody is detected, even if her TSH is normal, then you perform TSH on an yearly basis. It's a level C evidence. So if both antibodies are negative and you know that this patient has gone into POI, then there is no indication to retest later in life unless you suspect some symptoms, because this cause was not because of autoantibodies. Now, special points. There is no recommendation to screen for diabetes or any kind of infections, so torch test and things like that are totally out. Any medical or surgical procedure causing POI needs to be discussed and to take prior consent, especially when you are doing surgeries for endometriosis. And it's very, very important to discuss that endometriosis in itself can cause reduced ovarian reserve. And on top of it, any ovarian surgery can reduce the ovarian reserve. And now in today's world, we need to discuss fertility preservation, even if we are dealing with unmarried young girls. Now, significant number of POI, they remain unexplained or they remain idiopathic. And yes, that is, of course, the cause, and we see it all the time. So, in a nutshell, I have to tell, you do a karyotype for diagnosis of Turner syndrome or a Turner mosaic. Also look for any Y component in the Turner, because you could have mosaics with Y. Refer to endocrinologist, cardiologist, and geneticist. A second analysis of the karyotype in epithelial cells in cases of high clinical suspicion. Now, if you find a Y chromosomal cell line, or for example, I just today saw a girl for whom I have done gonadectomy 1 year back, and she had a gonadoblastoma. This girl is only 16 years old and has Swyer syndrome. So after gonadectomy, now after 1 year, all the tumor markers are normal, and now I have started her on first HRT so that she gets, some height, she gets uterine growth, and she gets cyclical menstrual cycle. So you discuss gonadectomy with the patient. In fact, I remember in last 3 years, I have done 3 Swyer syndrome, and all 3 presented with POI, and all 3 had XY chromosomes in the karyotype, and all the 3 had a gonadoblastoma and had to be under follow-up, but was just restricted to the gonads. Now, Fragile X syndrome, if it is positive, you have to refer them to geneticist. Autosomal genetic testing antibodies, 2 have been recommended. One are anti-adrenal antibodies and one is anti-TPO antibodies. Now, if they are positive, again, refer them to endocrinologist. And if anti-TPO antibodies are positive, test TSH every year till the time you find that she is getting hypothyroid. Now, retest in case of clinical signs or symptoms. Now, do you think relatives need to be offered genetic testing if you have diagnosed? Yes, relatives of women with Fragile X premutation, you should offer them. Currently, there is no predictive test for POI and no measures to prevent POI in relatives of women with non-iatrogenic POI unless a known mutation is known. And if POI is suspected, oocyte cryopreservation can be promising. Now see this case. This girl, these were 2 sisters. They came to me. The elder one was having both unmarried, and she presented with secondary amenorrhea. She had a catastrophic, cessation of menstruation. Her FSH had reached 100. And then I did her Fragile X premutation. And if you can see, there were 87 copies, and which was positive. So if you see the reference range, less than 45 was normal, 45 to 54 are intermediate, and 55 to 200 copies are full-blown mutation. So what I did was I did her sister's premutation, and her sister's premutation, the copies were 32. So the discussion, the father was very intelligent. And for the first sister, nothing could be done because she was in established, amenorrhea. But he started discussing, can the second sister donate oocytes and freeze the oocytes for her elder sister? And the first counseling, of course, was, is my other daughter carrying a gene? And if she is, then right now she's getting her regular menstrual cycle, her FSH is normal, and can we freeze the oocytes? So in some time, the younger sister will come as an egg donor and will freeze the oocytes for her elder sister going through the ART bank. So this is one place where Fragile X, premutation. In Gangaram, it is done by the name of Fragile X female. So there are 2 or 3 which we can do it. And if it is a possibility, so when you can, it will be of much use. Suppose you are able to catch these patients early in life where they just have menstrual deficiency, and you see that they are positive for Fragile X. That is the time where FSH is slightly rising. You can offer them oocyte cryopreservation if they are unmarried, and that is the only way they can, have their own fertility preserved. Now, this is another girl whom I'm treating. She's 23-year-old, presented with primary infertility. Height was 172 centimeters. Her baseline FSH is 15. She was menstruating regularly, but shorter cycles. And her karyotype she had brought in that report to me was 47XXX. So she is a super female. And we know that people with extra X chromosome can land up in premature ovarian insufficiency. So what I'm doing is I did one cycle of ovarian stimulation for her. She made one follicle with gonadotropin. She did not get pregnant. Then she wanted to go through an IVF cycle. With the highest dose of gonadotropin, I could make one blastocyst, and I'm doing a second cycle right now, and I'm accumulating blastocysts for her, and then I will start the embryo transfer process. Now, what is the life expectancy? Untreated POI will have reduced life expectancy due to cardiovascular disease. So what are the other factors which they have to specifically take care? Stop smoking, regular weight-bearing exercises, maintain a healthy weight, and early initiation of HRT. So this is what other things what we need to do as a gynecologist when these girls come to us. Now, if we are dealing with girls with Turner syndrome, then annual checkup of their blood pressure, quitting smoking, weight management, lipid profile, fasting blood glucose, and HbA1c should be performed on an yearly basis. One, yes, they have coarctation of aorta, higher risk, so a cardiac consultation is very important. Now, what about the obstetric outcomes? Spontaneous pregnancy after idiopathic POI or chemotherapy do not show any higher obstetrical or neonatal complications, so do not get so alarmed. Oocyte donation pregnancies are at a higher risk and they should be disclosed to the treating obstetrician. Special emphasis in managing pregnancy in Turner syndrome, which I said higher incidence of obstetrical and non-obstetrical complication involve a cardiologist. Also involve a cardiologist in patients who have received anthracycline and cardiac irradiation. That is important. Now, chance of spontaneous conception, it's not that people with POI will not conceive at all. And you can recall in your practice that every time you have said that, oh, the ovaries have conked off, and suddenly somebody will come up with a spontaneous pregnancy. So up to 25% can show some evidence of ovarian function, at least 2 consecutive menstrual cycle or pregnancy, and 4.8% women may have a spontaneous conception. So predictive factors they include are serum estradiol, inhibin B, and ultrasound for AFC, but not so much related to AMH. AMH cannot predict pregnancy. So please remember that AMH is a molecule which is more helpful if you are planning an IVF, but for a natural conception, even a low AMH does not predict. Now, what are the treatment to increase the natural pregnancy? You can give them estrogens, ethinyl estradiol, a higher dose. But now what we have estradiol valerate, we have estradiol hemihydrate, and we have conjugated equine estrogen, and we have ethinyl estradiol transdermal gels in India. For fertility, if they are the case I just showed, 47XXX, I'm giving her gonadotropin, so you can challenge them, provided their FSH is less than 15 with a shorter duration of amenorrhea, and corticosteroids if it is an autoimmune cause. Now, estrogen can lower the FSH and help in follicular genesis, and dexamethasone may be helpful in autoimmune cases of POI. Fertility intervention, no intervention has shown to increase the chance of ovarian activity, and natural conception isn't established in POI cases. Otherwise, it will be oocyte donation. If totally she's gone into POI, like the first 2 sisters I showed, FSH is 100. She is a carrier of Fragile X mutation, and now she has gone in full-blown POI. Women considering oocyte donation from sisters might have increased chance of cycle cancellation, and that is why for the next sister, I did that test. Newer methods of fertility preservation like oocyte cryopreservation and ovarian cortex cryopreservation are there. Only thing is that in India, we still don't have reported cases after ovarian cortex reposition. Who can be offered fertility preservation? Highly selected cases of Turner syndrome, survivors of childhood or adolescent cancers, and sisters of women with POI. Now, how to get pre-pregnancy fitness? They need thyroid and adrenal function test. They need a karyotype. They need an ECG if received cyclophosphamide, anthracycline, or mediastinal irradiation. They need evaluation for congenital heart disease in cases of Turner syndrome. They need blood pressure check and renal function evaluation. Now, How do you monitor bone health for them? So at the initial diagnosis of POI, if initial BMD is normal, you initiate estrogen therapy and no need to repeat BMD. If initial BMD is low, initiate estrogen therapy and repeat BMD within 5 years. And if still low, you reevaluate your estrogen therapy, increase the dose, change the molecule. Combined OC pills have less favorable effect on BMD and so give sequential estrogen and progesterone, which are recommended. Now, what about their sexual life? Psychosexual life can be greatly hampered, which I just gave an example of my patient who has now heading towards POI. Even with gonadotropin, she has low estrogens and is not able to have sexual contact unless I give her an exogenous estrogen along with the stimulation. Now, adequate estrogen therapy is a start big point for normalizing sexual function. They may need vaginal estrogen therapy and lubricants for genitourinary symptoms, and they are also very prone for urinary tract infections. Now, HRT, are there any risks? They have not found any risk of breast cancer before the age of natural menopause. Progesterone to be given in combination with estrogen to protect endometrium. Which estrogen? 17-beta estradiol is preferred over ethinyl estradiol or conjugated equine estrogen. Yearly checks for compliance, no other tests are required. So if we are giving estrogens, 17-beta estradiol is more physiological, less effect on the lipid profile. We have this as transdermal gel, and if I have patients who have any liver issue, I like to give a transdermal gel. Ethinyl estradiol gives a supraphysiological level, more effect on lipid profile.
Sorry, Dr. Shah,
No risk of
request Dr. Lata Anand to please mute yourself. Dr. Lata Anand, please. Yeah, Dr. Lata, mute. Thanks.
And when it comes to conjugated equine estrogens, there are no studies to compare conjugated equine estrogen to 17-beta estradiol, possibly with similar effects. So we have oral estradiol, which is our brand names like Proginova, Estrabet, but there are many, Evatab, 2 to 4 milligrams. We don't have transdermal gels. We have gels, but we don't have patches. They can bring the highest bone mineral density. Your target is that the serum estradiol levels should be between 50 to 100 picograms per ml. And if you're using conjugated equine estrogen, then 0.625 milligram per day. Now, which progesterone to be added? This comes in the mind of gynecologists. To prevent endometrial hyperplasia or cancer, you can add micronized progesterone 200 milligram daily for 12 days in a 28-day estrogen cycle, or you can add medroxyprogesterone 10 milligram daily for 12 days, or you can give medroxyprogesterone 2.5 milligram daily through the cycle. So we have different pills which are available in India, but I like to give a pure estrogen and a progesterone I add along with the pure estrogen when I want better uterine growth. Not more than 3 months of continuous estrogen therapy. Cyclical ONP are preferred. So the first withdrawal bleed for them can be continuous. And the moment they get their first withdrawal bleed, then go into sequential estrogen and progesterone. Special situations, HRT is contraindicated in breast cancer survivors. If no breast cancer but carrier of BRCA1 and 2 BRCA, they can be offered HRT after prophylactic bilateral salpingo-oophorectomy. In endometriosis, patients who underwent oophorectomy, combined OC pills can be effective. For migraine sufferers, obese patients, and high risk of thromboembolism, transdermal estrogen has the lowest risk. Hypertension, fibroids are not a contraindication for HRT in these patients. How do you induce puberty? 17-beta estradiol at age of 12 years with gradual increase over 2 to 3 years. Transdermal estrogen more physiological. OC pills are contraindicated. Begin progesterone after 2 years of estrogen or when the first breakthrough bleed occurs. So this is what I've done for this girl. In the first month of estrogen, she had a breakthrough bleed and I have put her on cyclical estrogen and progesterone. What are the modifiable factors? Gynecological and surgical practice, lifestyle, smoking, modified treatment regimes for malignant and chronic diseases. So to conclude, premature ovarian insufficiency needs a multidisciplinary approach. Fertility preservation can be offered to women with suspected POI of a known mutation causing POI. Oocyte donation still remains the method of achieving fertility in established cases of POI. Bone health and reducing risk of cardiovascular event is an important aspect in these women. Thank you so much.